part 2 of the voiceover is now going to focus on lower respiratory problems. So we're going to dive right in. The first disorder that we talk about is something called bronchitis. And in the previous video, I talked about paying attention to the prefixes and the suffixes. So itis, again, inflammation, in this case, the bronchi. So you see how the bronchi are here, and there's inflammation going on to that bronchi itself. And it's primarily caused by viral infections. So we have the inflammation, which is leading to swelling. We're also having some increased mucus production along the airways itself. Now, the most common symptom that patients have when there's inflammation of the bronchi is coughing. It can be very dry, or it could be productive, meaning that they're producing sputum or spit, and it can change in color. It could be a clearish tone, or it could also be purulent sputum, so that yellowy, greenish sputum. Now, other symptoms that patients may experience are a headache, fever, aches, dyspnea, which is shortness of breath, and chest pain. And these symptoms typically reflect our body's response to the infection or that irritation of the airways. And then that's what this picture is kind of representing. So if you look internally of the bronchial tube, it should be open, so it's easy for air to come in and out, versus in bronchitis, you can see that there's clear inflammation of the lining of the bronchial tube. And if there's mucus as well, it makes it even more constricted, so harder to breathe. Now, how do we diagnose this? Honestly, it's mostly based off of assessment findings, so the subjective and objective data of your patient. So we're going to listen to the patient's breath sounds. With the breath sounds, when there's bronchoconstriction, we could hear some wheezing, but if there's a lot of mucus, we can also hear some crackles, especially on expiration. So it tends to start with expiration first. And this clearly is an indication of the inflammation and the mucus in those bronchial tubes. Now, we also will get a chest x-ray, but the chest x-ray is more so to rule out other worsening conditions like pneumonia. So on a chest x-ray of a patient that we suspect, could it be bronchitis or could it be pneumonia? This is kind of the factor that tells us if it's normal, then we can just say that it is acute bronchitis. So a chest x-ray would be normal. And again, it helps us differentiate from other conditions like pneumonia. And on a chest x-ray, you can see pneumonia present, and it'll show that the lungs are infiltrated. Now, what kind of treatment do we do for acute bronchitis? Well, really, it's just symptom relief and prevention of pneumonia. So we'll tell the patient to take cough suppressants if the cough is severe enough where it's causing them distress. We would encourage oral fluids, right? Because if they have a lot of mucus, we drink a lot of fluids to thin out those secretions, and it helps us to get rid of those secretions in the lungs. So it helps us expel those secretions a lot more easier, versus if they're super thick, they kind of get stuck. We can, if their cough is severe and it's causing a sore throat, we can recommend remedies that would soothe the throat, like lozenges or hot tea and honey. If the bronchoconstriction is so bad where the patient is having a lot of wheezing, we can actually give a bronchodilator. And we're going to talk about this when we get into chronic diseases like asthma and COPD, where there's this chronic inflammation of the airway, and bronchodilators help to dilate, right? So if there's constriction, it's going to open up those airways and just make it a lot easier to breathe. Bronchodilators are especially useful in conditions where the patient has these chronic conditions like COPD and asthma, like I said. And then we're going to educate our patient to avoid any irritants. So smoking should definitely be stopped. Smoking is an irritant. It can exacerbate the symptoms of bronchitis. And then if the bronchitis is secondary because of influenza, so they had the flu. If they caught the flu early enough, remember those first 48 hours, we could give the antiviral Tamiflu. That kind of lessens the symptoms. And then preventative measures. So patients should be wearing masks if they're going out in public. One, to protect the public, but two, to prevent themselves from other irritant exposure like pollution or secondary smoke. All right. Question 1, when we come to the lower respiratory. When caring for a patient with acute bronchitis, the nurse will prioritize interventions by, is it A, auscultating lung sounds, B, encouraging fluid restriction, C, administering antibiotic therapy, or D, teaching the patient to avoid cough suppressants? Well, bronchitis is mainly diagnosed off of a history and a physical. We would get a chest x-ray if we suspect it could potentially be a worsening condition like pneumonia. We would encourage fluid intake to thin out secretions if they're having a lot of thickened secretions. This is mostly caused by viruses, so patients should not be on any antibiotic. And then we encourage cough suppressants if the cough is so severe and causing a lot of pain. So the answer here is A, right? What kind of lung sounds should we hear with bronchitis? Well, it depends. If there's inflammation, we could hear wheezing. If there's a lot of mucus production and essentially fluid building up down in the lungs, we could hear some crackles. That then brings me to pneumonia. So pneumonia, as we were kind of talking about in the previous, right, to rule out pneumonia, we would get a chest x-ray. Now, pneumonia is the 4th leading cause of death in the United States. It's highly associated with a lot of significant morbidity and mortality rates, especially in the geriatric community. And basically what's going on is we're in the lower respiratory. This is an infection of the lung. It's an infection that is affecting the alveoli. It could affect the pleural space and overall the lung health. So I'm going to share this video.
Pneumonia is an infection in the lung tissue caused by microbes, and the result is inflammation. The inflammation brings water into the lung tissue, and that extra water can make it harder to breathe. During inhalation, air reaches your lungs by traveling down your trachea. Then it continues through the bronchi and the bronchioles and ends up in the alveoli. The alveoli are tiny air sacs that look like tiny clumps of grapes that are wrapped up in a net of capillaries. This is where the majority of gas exchange happens in the lungs. Oxygen leaves the air in the alveoli and crosses into the bloodstream, while carbon dioxide leaves the bloodstream and then is exhaled out of the body. Now, in addition to air, you're constantly breathing in other stuff, like microbes. But we're usually pretty good at protecting ourselves. For example, we have mechanical techniques, like coughing, a mucociliary escalator that lines the entire airway and moves out larger bacteria, and macrophages that are nestled deep inside the alveoli and ready to destroy anything that lands there. But sometimes, a particularly nasty microbe might succeed in colonizing the bronchioles or alveoli. And when that happens, congratulations, you've got pneumonia. Those microbes typically multiply and cross over from the airways into the lung tissue, creating an inflammatory response. The tissue quickly fills with white blood cells as well as proteins, fluid, and even red blood cells if a nearby capillary gets damaged in the process. Now, there are lots of different pneumonia-causing microbes. Usually it's caused by viruses and bacteria, but it can also be caused by fungi, as well as a special class of bacteria called mycobacteria. In adults, the most common viral cause of pneumonia is influenza, sometimes just called the flu. In adults, bacterial causes include Streptococcus pneumoniae, Haemophilus influenzae, and Staphylococcus aureus. There are also more unusual bacteria like Mycoplasma pneumoniae, Chlamydophila pneumoniae, and Legionella pneumophila, which don't have a cell wall and are well known for causing an atypical or walking pneumonia, because they often cause vague symptoms like fatigue. In individuals with a normal immune system, fungi are a rare cause of pneumonia, and often it's regional. For example, there's coccidioidomycosis in California and the Southwest, which you can remember because there's a C in both cocci in California, histoplasmosis in Ohio and the Mississippi River valleys, H in histo and H in Ohio, and blastomycosis, which are broad-based budding yeast in the East. You can remember that with Eastern yeast. And the broad-based budding refers to the fact that under a microscope, when the fungi bud off each other, there's a broad versus a narrow base. To round out the fungal causes in the US, there's Cryptococcus, which is cryptic because geographically it can pop up really anywhere. Now, one special fungal culprit is Pneumocystis jirovecii, which is a risk for immunocompromised individuals. Finally, there's mycobacteria, which are slow-growing like fungi, hence the myco in their name, even though they're still bacteria. The most well-known one is Mycobacterium tuberculosis, also just called TB. Now, pneumonia can also be categorized by how it's acquired. The most common is community-acquired pneumonia, and it's called that when a person gets sick outside of a hospital or healthcare setting. Next is hospital-acquired pneumonia, or nosocomial pneumonia, which is when a person gets pneumonia when they're already hospitalized for something else. This type tends to be more serious, because sick patients often have a weakened immune system, and the microbes in hospitals are often resistant to the common antibiotics. That's because hospitals bring together the bacteria that are often the most virulent, think great offense, as well as the most resistant, think great defense. And these bacteria are able to swap some of the antibiotic resistance genes with each other. A well-known example is methicillin-resistant Staphylococcus aureus, or MRSA. Non-resistant Staph aureus can cause pneumonia and other infections, but it can also be killed by common antibiotics, like ampicillin. MRSA, on the other hand, is resistant to many antibiotics, and is therefore harder to treat. Another category of pneumonia is ventilator-associated pneumonia, which is a subset of hospital-acquired pneumonia, but it specifically develops when ill individuals are connected to a ventilator. Oftentimes there's a biofilm, which is a mix of bacteria, sugars, and proteins that can coat a surface, that forms on the endotracheal tube. Individuals on a ventilator can't cough, and are often pretty sick already, so over time microbes can move from the tube directly into the lung and cause a pneumonia. Now, in addition to inhaling microbes, there are also other ways to develop pneumonia. Think about this. You're eating some French fries, and instead of swallowing one, you accidentally breathe it in. Informally, we call that going down the wrong pipe, but we could also say that you aspirated that French fry. Normally, you'd automatically gag and start coughing, and work that French fry out of your lungs. These gag reflexes can be compromised, though, by drug and alcohol abuse, brain injuries, or swallowing issues. So in these cases, the French fry might stick around in your lower airways. Now, of course, that French fry isn't sterile, and there might be some microbes stuck to it. If those microbes infect the lungs and you get pneumonia, we would call that French fry pneumonia. Nope, just kidding. It's called aspiration pneumonia. Aspiration pneumonia can also happen with drinks or even gastric contents, like after a bout of vomiting. Aspirated gastric contents can be particularly nasty because the stomach acid can cause a chemical irritation in addition to the possible infection. Another way we can characterize pneumonia is by where the infection is. In bronchopneumonia, the infection can be throughout the lungs, involving the bronchioles as well as the alveoli. In atypical or interstitial pneumonia, the infection is mainly just outside the alveoli in the interstitium. And in lobar pneumonia, the infection causes complete consolidation of a whole lobe of the lung, meaning that the entire region is filled with fluid. The vast majority of these are caused by the Streptococcus pneumoniae. Usually, lobar pneumonia happens in stages. The first stage is congestion, and it happens between 1 and 2 days. This is where the blood vessels and alveoli start filling with excess fluid. The next stage is red hepatization, and it happens between days 3 and 4. This is where exudate, which contains red blood cells, neutrophils, and fibrin, starts filling the air spaces and makes them more solid. The name hepatization refers to the lungs taking on a liver-like appearance from the reddish-brown color of the exudate. The third stage is gray hepatization, which happens around days 5 to 7. In this stage, the lungs are still firm, but the colors change because the red blood cells in the exudate are starting to break down. The last stage is called resolution, and this happens around day 8 and can continue for 3 weeks. In this stage, the exudate gets digested by enzymes, ingested by macrophages, or coughed up. Pneumonia most often causes dyspnea, or shortness of breath, as well as chest pain and a productive cough, meaning that pus or bloody sputum might come up. Often there are also systemic symptoms, like fatigue and fever. Diagnosis of pneumonia is usually made in a person who's working hard to breathe or breathing quickly. A chest x-ray of bronchopneumonia typically shows patchy areas that are spread out throughout the lung. In atypical or interstitial pneumonia, the pattern is also often spread throughout the lungs, but it's often concentrated in the perihilar region and looks reticular, meaning there will be more line-shaped opacities visible in the chest X-ray. In a lobar pneumonia, fluid's localized to a single lobe or set of lobes. Another way to detect lobar pneumonia, though, is to look for dullness to percussion, which suggests that there's lung consolidation. There's also tactile vocal fremitus, which is when you can feel more vibrations from a person's chest or back after they repeat certain phrases. This is because sound travels better through the fluid-filled consolidated tissue than air-filled healthy tissue. Late inspiratory crackles might also be heard, along with bronchial breath sounds, bronchophony, and egophony. The treatment of pneumonia depends on the type and severity of pneumonia. Since bacteria are the most likely cause, antibiotics are often prescribed. In addition, cough suppressants and pain medications are often used to help with symptoms. Alright, as a quick recap, pneumonia is an infection of the lungs that results in air sacs being filled with fluid. The disease can be classified by being either community-acquired, hospital-acquired, with some of those being ventilator-associated pneumonias, or aspiration pneumonias. Pneumonia can also be characterized by where the infection is in the lungs. Bronchopneumonia is spread throughout the lungs. Atypical or interstitial pneumonia happens in the interstitium around the alveoli, and lobar pneumonia usually infects an entire lobe of the lung.
Hi everyone.
All right, so I feel like the video does a good job. I like to show videos because sometimes seeing it and in a different perspective and visualizing with the pictures I find very helpful, at least for my learning habits, so I try to incorporate that as well. So now just going through the slides, the video talked about how pneumonia is obviously an infection of the lungs, and it can be caused by a variety of things, as you had seen, bacteria, viruses, even fungi. And this type of trigger or infection causes this inflammatory response in the alveoli themselves, so in those air sacs, which we know are primarily responsible for gas exchange. So if the alveoli are affected with filling with fluid or pus or some sort of increased air or cellular debris, then the gas exchange is inefficient, right? So oxygen cannot move into the blood as well, and carbon dioxide can't move out. So the key concept I want you to remember here is pneumonia is about alveolar filling, not just airway obstruction. All right. In terms of the cause, the etiology, it could be from a variety of different organisms. It's also classified as community acquired versus hospital acquired. And within hospital acquired, we also have what's called ventilator acquired pneumonia. And we're going to kind of talk about that when we talk about nursing care. Hospital acquired, though, it tends to be a lot more serious and more resistant to antibiotics. Now, the epidemiology, older adults, the geriatric community, 65 and older, are at an increased risk just because of their weaker immune system, also because they have a decreased cough reflex, and they have a lot of comorbidities. Also, those who have chronic lung disease, so patients with COPD or asthma, or if they have an intensive smoking history, they're just at a higher risk because their lungs are already compromised. And that is why pneumonia remains as one of the leading causes of hospitalization and death in the older adults. All right, so what type of signs and symptoms are you going to see? Well, number one is a cough. It can either be productive, where we're producing mucus, or non-productive. And the color of the mucus can actually give us a little bit of a clue in terms of what type of infection is happening. If it's green or yellow, it can suggest a bacterial infection. But if it's like a rusty color, it could indicate something more severe is happening, a more severe infection, or even blood. Fever and chills is common. It's a common sign of infection, and when you have a fever, it's typically accompanied by chills. Patients may complain of severe shortness of breath, or they may even have tachypnea, which is just they're breathing a lot faster to try to compensate. They'll complain of pleurotic chest pain, so this is pain that gets worse when they're taking those deep breaths or cough. Pneumonia wipes people out. So patients are very, very tired. They're extremely weak. This is impacting their activities of daily living. they're using extra muscles to breathe, right? So you may see the substernal muscles, you may see retractions in between the rib cages themselves, or even using additional abdominal muscles. And that is a clear sign that they're in respiratory distress. You could see nasal flaring. This is a sign of difficulty breathing, but this is especially seen in younger children. And then when you're inspecting, right, you want to see that the chest, is it moving unilateral? Is it asymmetrical? And so that is a clear sign that one side of the lung is more affected than the other. And then your heart is very much connected to the respiratory system. So your heart is trying to compensate. Your heart gets elevated, so you're going into tachycardia. And it can just be a response to the infection and the fever. Now, in older patients, additional signs that you might see is confusion. So older adults could show signs of that confusion or even just decrease alertness. And then, believe it or not, I know our mind always jumps right to hyperthermia when we're thinking about infection, but sometimes it's the opposite for the geriatric community. So instead of fever, patients may present with a lower than normal body temperature. So that would be a clear sign that you would have to cluster these cues together. And it has something to do with the hypothalamus and regulation of our body temperature decreases as we get older. Diagnostics, it's going to be, the first step is always doing a history. It's doing a physical exam, doing the whole process of inspection, palpation, percussion, and auscultation. But we're going to get a chest x-ray. Just like we said we got a chest x-ray for bronchitis. That would be normal. But in this case, sometimes the signs and symptoms of all of these diseases kind of could mimic each other. So we really need diagnostic tools to kind of eliminate one versus the other. And the x-ray will do that. So you can see pictures here. A radiologist tech is the one reading it. It's not up to the nurse to decide, oh, it's this type of pneumonia, right? So you are just helping the patient get situated for the chest x-ray. Once the report comes back, then from radiology, the primary provider will look over it, and then treatment methods will be started from there. So chest x-ray is going to show us what type of pneumonia it is. In addition to that, we could do other studies like a thoracentesis or a bronchoscopy. So I talked about a thoracentesis when we were talking about the pleural space, and if it has increased fluid buildup in that pleural space, I was talking about a pleural effusion. So a thoracentesis is basically where we go in with a needle to remove excess fluid around the lung, and we can test that fluid for infection. A bronchoscopy, anytime you hear a scope, it's where we're looking in with a camera. In this case, bronchoscope, right? So a thin tube with a camera is actually going into the airway itself, and we can collect samples that way and send it off to lab. A pulse ox is part of our vital signs, so we're looking at the oxygenation within the blood, and it might be low with pneumonia. ABGs. So we know what ABGs are. ABGs are, or VBGs. In this case, it's arterial, or it could be venous. So it's whatever the provider orders. But it's a blood test that tells us how well the patient is oxygenating. It gives us our levels of the blood, our oxygen, our carbon dioxide. It also gives us other things like bicarb. But we'll kind of get to that in MedSearch 3. All right, so we'll get some ABGs. We'll also get a sputum test. So if the provider doesn't do a bronchoscope where they're taking the fluid out for samples that way, or a thoracentesis, we can just get a simple sputum. So the patient hacks up sputum, we'll collect it, and then send it off to the lab to see what type of germ comes back. And then blood culture. So we want to ensure that the infection doesn't spread throughout the rest of the body and get systemically. So that's just detecting if there's any bacteria that's present in the blood. This is a sign of septicemia. It helps us guide our treatment as well. Any type of culture, whether it's a blood culture, whether it's the sputum test, whether it's the bronchoscope, we need to get a sample of whatever type the provider wants prior to starting an antibiotic, because it can affect the result of that culture itself. So remember, any type of cultures we get first, and then we can start broad spectrum antibiotics. Broad spectrum is just a variety of bacterium that this antibiotic fights, and it tends to fight a variety of them. That's why it's called broad. Once that report comes back from that culture, we can narrow in and say, this is the actual bacterium, and we know that this antibiotic works best against that bacterium. So normally, infectious disease is the one overseeing this. They are the specialists, and they'll guide the primary care team in terms of what we should be doing, what type of antibiotics this person should be on. Are they responding? How do we transition them from IV antibiotics to then PO antibiotics? So we're always guided by those experts, and we work as a team. And then in addition to that, we can get a complete blood count. Now, what would we be particularly looking at in a complete blood count? Let's think about this. There's a lung infection happening. I hope your mind went right to a white blood cell. All right, so the white blood cells are likely to be increased. This is leukocytosis, so it's an indication that your body is fighting some sort of infection. So we would expect to see an increase in the white blood cell count. Now, what is our role as the nurse? How do we manage a patient that has pneumonia? Well, antibiotics is the treatment if it is a bacterial infection. Patients tend to really improve within 48 to 72 hours when we start the antibiotics, and we'll start to see that the fever starts to go down, their breathing improves, and then they'll just overall say that they feel a lot more comfortable or at ease. Very important, remember that, like I said, any type of, when we're talking about the diagnostic, any type of sputum or culture has to be collected before we start those antibiotics though. Once the patient's starting to feel better, if they're on the verge of going home and we're sending them with a PO antibiotic, the provider may actually request them to get a repeat chest x-ray within 6 to 8 weeks, just to confirm that the infection has resolved. They'll probably especially do this in the population that is a higher risk, like geriatrics and those who already have chronic lung conditions. The best thing that we can do too is educate the patients on prevention, especially the geriatric community who is at a very high risk and those who already have chronic lung disease, to get the pneumococcal vaccines. And there's 2 different types. It's basically essential. It just helps prevent this from occurring. And then in addition to the antibiotics, we're going to give supportive care. So oxygenation for those who are hypoxic. If those patients are having pleurotic chest pain, we're going to give some analgesics for pain relief. For the fever, we may give antipyretics. So you can kill 2 birds with 1 stone. Tylenol is very helpful for an antipyretic, but also an analgesic for pain relief. They don't obviously cure pneumonia, but they help stabilize the patient's symptoms. Now, your role as a nurse is to recognize the severity of the patient and if their condition is worsening or not. So in that geriatric community, if you have a patient that's 65 and you know they have pneumonia and we're doing all this supportive care and we're giving them antibiotics and you just kind of see that they're worsening, now they're developing confusion or their oxygenation is increasing, their oxygenation requirements are increasing, right? So they're getting more and more hypoxic. These are very early signs of deterioration, and you need to communicate to the provider that they may need to advance care and go into the ICU. Now, anxiety is another potential complication that is very much so associated with individuals who have difficulty breathing because it's very frightening. So you want to make sure that you're sitting your patient upright, you're educating them on pursed lip breathing, so that's like puckering your lips and trying to do an extension of the exhalation to remove that carbon dioxide. It does help reassure them, it helps reduce anxiety and overall improves their oxygenation. Also, education is key here. We have to, if they're smokers, we have to reinforce that they need to stop smoking. Smoking impairs our lung defenses and it can increase their reoccurrence risk as well. Now, because patients could have a lot of mucus development and productive sputum, we're going to tell them to drink some fluids. It's going to thin out those secretions. It's going to make it a lot easier to expel. Now, because pneumonia takes a lot out of people, they're burning calories. And sometimes just eating food is exhausting for them. So we're going to recommend that they have smaller, more frequent meals that are high in calories. It helps just conserve their energy, but it also provides the nutrition during recovery that they need. And then rest. Rest is very important, but also a balance, right? They still should be having a little bit of mobilization, some gentle mobilization, even if it's just getting up, sitting on the side of the bed, standing up for a minute, sitting in the chair with meals. That goes such a long way because we don't want the patient to also get deconditioned. Stress the importance if patients are going home to continue to take the full antibiotic course. Remember that stopping early can lead to resistance and relapse. And then just going back, one slide that I want to add in here is just how to manage respiratory acquired pneumonia. So in a patient that, has a ventilator, we want to reduce the risk of aspiration of any gastric secretions into their lungs. So they should be in a semi-Fowler's position, like 30 to 45 degrees. In addition to that, right, you're learning about suctioning in 341 lab. It should be sterile procedure because you don't want to introduce any bacteria into that airway itself. You also, just because the patient is intubated or trached, you can still provide oral care to them. And we typically do this with a chlorhexidine solution, usually twice a day, so every 12 hours, just because gunk can build up in the mouth, and you really want to be cleaning it out. Now, we have special devices in the hospital now where you can brush the teeth and suction them at the same time, so there would not be a risk for aspiration. And then you want to make sure you're strict with your hand hygiene before and after any contact with a patient with a ventilator or an airway. And again, remember, sterile technique when suctioning. And then in addition to that, just some general care. If we can begin early enteral nutrition as early as possible, we want to ensure that the patient is adequately hydrated and their position is promoting lung expansion. All right. Moving then on to aspiration pneumonia. So aspiration pneumonia was it talked about in this last video? Very briefly, I feel. So basically, aspiration pneumonia is when food or liquid or even the gastric contents are inhaled into our lungs instead of being swallowed down our esophagus and then into our stomach. So this can lead to a major infection in the lungs and can actually increase the risk of morbidity and mortality. So there's a couple major risk factors for aspiration pneumonia. One is decreased level of consciousness. So when a person is unconscious or even just semi-conscious, they're more likely to accidentally inhale substances. This could be because of a depressed cough or gag reflex. So that's our body's natural reflex. And if it's weakened, then it's easier for food, liquid to enter into our airways. Do you ever swallow something too quickly and you just cough, right? That's your body's natural defense. And this could be delayed in a patient that has decreased level of consciousness. Then you have dysphagia, so difficulty swallowing. If someone's having difficulty swallowing, right, then it could go down the wrong way and enter into the lungs. In addition to that, there are things called NG tubes, nasogastric tubes. It goes into the nasal cavity, down the back of the pharynx, all the way down the esophagus, then into the stomach. This has to be confirmed with a chest x-ray to ensure that we're in the right place. And then we can use a nasogastric tube for a variety of things. We talked about nasogastric tubes in terms of decompressing the stomach when a patient had an ileus, right? That the delay in their bowel functionality because of anesthesia or some sort of abdominal surgery. Nasogastric tubes can also be used for feeding, so you just have to see what the indication is. If it's used for feeding, it's normally just a short-term fix to a problem. If it's going to be where a patient's going to need long-term feeds, then we would do a PEG tube or a J tube, and we'll get to that when we get to GI. But this is a risk factor because it's just inserted and then secured on the nose with tape. There are measurements on the NG tube itself. I'm going to bring one into class to show you guys. But your job as the nurse is to ensure that it is in the same exact spot that it was put into. And now you document this in the flow sheet of the lines, drains, and airways. So any lines, drains, or airways are documented, and every shift you're to document on there. So when someone puts in an NG tube, it will tell you the exact location it's supposed to be, and it's something that you should get in report. So part of my assessment, every time I go in there, I just peek my eye on it and make sure that it's still in the right place. Sometimes it looks like it may be in, but the tape can loosen up, especially if patients are sweaty or they're hairy, etc. It can loosen. And if it loosens, right, and dislodges and it comes out of the esophagus and is sitting here and you're feeding that patient, then that food is just going to pour into the airway. So, or if you have a confused patient and they're yanking at it and it dislodges and they're going to be on a continuous feed, you're not going to know until you come in and see the situation at hand. So you just got to be very mindful to that. So preventative measures, you want to have the patient who are at risk, have them sit up. You want their head of bed elevated in a semi-Fowler's position, and definitely sitting up for all meals, whether they have an NG tube or not. You may have them on an assist, so they have either a one-to-one assist that stands there and just makes sure they're safe while they're eating or drinking or they're taking their meds. Part of your assessment as a nurse is to assess for a gag reflex, because if it's absent, then you know they're at an extreme risk for aspiration. Early mobilization is very helpful to promote lung expansion, to prevent pneumonia. And then we would educate on coughing and deep breathing techniques, incentive spirometer, and then that oral hygiene care that I was talking about, especially helpful with those that have ventilator-acquired pneumonia. All right, now we get into tuberculosis.
Learning medicine is hard work. Osmosis makes it easy. It takes your lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today. It's estimated that about 2 billion people worldwide are infected with Mycobacterium tuberculosis, often just shortened to tuberculosis or simply TB. 2 billion is a ton of people, but even though they're infected, that doesn't mean that all these people have symptoms. The vast majority, about 90 to 95%, aren't even aware that they're infected. And this is because usually the immune system can contain it, such that it's not able to multiply. It often remains latent or dormant, as opposed to active, which usually causes symptoms and can be spread to others. If the host's immune system becomes debilitated at some point down the road, like with AIDS or some other illness, or as a person grows older, it can be allowed to reactivate, or basically wake up and become very serious, especially if it spreads throughout the body. Mycobacteria are an interesting bunch. They're slender, rod-shaped, and need oxygen to survive. In other words, they're strict aerobes. They've got an unusually waxy cell wall, which is mainly a result of production of mycolic acid. Because of this waxy cell wall, they're acid-fast, meaning that they can hold on to a dye in spite of being exposed to alcohol, leaving it bright red colored when a Zeal-Nielsen stain is used. The wall also makes them incredibly hardy, and allows them to resist weak disinfectants and survive on dry surfaces for months at a time. Now, Mycobacterium tuberculosis is usually transmitted via inhalation, which is how they gain entry into the lungs. Now, we breathe in all sorts of virus and bacteria all the time, but we've got defenses that take care of most of them. For one, air that we breathe in is turbulent in the upper airways, and drives most bacteria against mucus, which is then cleared pretty quickly. Ultimately, though, TB can avoid the mucus traps and make its way to the deep airways and alveoli, where we have macrophages that eat up foreign cells, digest, and destroy them. With TB, they recognize foreign proteins on their cell surface and phagocytize them, or essentially package them into a space called a phagosome. With most cases, the macrophage then fuses the phagosome with a lysosome, which has hydrolytic enzymes that can pretty much break down any biochemical molecule. TB is tricky though, and once inside the macrophage, they produce a protein that inhibits this fusion, which allows the mycobacterium to survive. It doesn't just survive though, it proliferates and creates a localized infection. At this point, somebody has developed primary tuberculosis, which means that they have signs of infection soon after being exposed to TB. Even though it sounds bad, Most people at this stage are actually asymptomatic, or maybe have a mild flu-like illness. About 3 weeks after initial infection, cell-mediated immunity kicks in, and immune cells surround the site of TB infection, creating a granuloma, essentially an attempt to wall off the bacteria and prevent it from spreading. The tissue inside the middle dies as a result, a process referred to as caseous necrosis, which means cheese-like necrosis, since the dead tissue is soft, white, and looks kind of like cheese. This area is known as a gone focus. TB also gets to hilar lymph nodes, either carried over by immune cells through the lymph or by direct extension of the gone focus infection, and causes caseation there as well. And together, this caseating tissue and associated lymph node make up the characteristic gone complex. Gone complexes are usually subpleural and occur in the lower lobes of the lungs. The tissue that's encapsulated by the granuloma undergoes fibrosis, and often calcification, producing scar tissue that can be seen on X-ray. This calcified gone complex is called a Ranke complex. In some cases, although a scar is left over, the mycobacteria is killed off by the immune system, and that's the end of that. In other cases, even though they're walled off, they remain viable, and are therefore still alive, but they're just dormant. If and when a person's immune system becomes compromised, like with AIDS or with aging, the gone focus can become reactivated, and the infection can spread to either one or both upper lobes of the lungs. It's thought that this is because oxygenation is greatest in these areas, and TB, being anaerobe, prefers areas of greater oxygenation. Since they were previously exposed, the immune system's memory T cells quickly release cytokines to try and control the new outbreak, which forms more areas of caseous necrosis. This time, though, it tends to cavitate, or form cavities, which can allow the bacteria to disseminate, or spread through airways and lymphatic channels to other parts of the lungs, which can cause bronchopneumonia. But it can also spread via the vascular system, and infect almost every other tissue in the body, called systemic miliary TB. When TB spreads to other tissues, it causes complications related to the organ affected. Kidneys are commonly affected, resulting in sterile pyuria, or high levels of white blood cells in the urine. It might also spread to the meninges of the brain, causing meningitis, the lumbar vertebrae, causing Pott disease, the adrenal glands causing Addison's disease, the liver causing hepatitis, and the cervical lymph nodes causing lymphadenitis in the neck, also known as scrofula. Testing for TB often starts with a purified protein derivative, or PPD intradermal skin test, sometimes known as a tuberculin skin test, MAN2 test, or simply TB test. With this test, tuberculin is injected between layers of the dermis. Tuberculin is a component of the bacteria, and if a person has previously been exposed to TB, the immune system reacts to the tuberculin and produces a small, localized reaction within 48 to 72 hours. If the reaction creates a large enough area of induration, rather than just redness, it's considered to be a positive test. Positive tuberculin tests simply mean that the patient's been exposed at some point to TB. It does not differentiate between active and latent disease. As an alternative to tuberculin skin tests, there are also interferon gamma release assays, or IGRAs, which look for evidence in the blood of previous exposure to TB proteins. Since this one's a blood test, you do not need to show up again to have the test read like you do with a PPD. Also, the IGRA is more specific to TB rather than other types of mycobacterial infections, and is unlikely to be positive as a result of having BCG vaccine in the past, a vaccine that protects against TB. And this is a pretty useful feature of IGRAs, since BCG vaccine is given to many children around the world to prevent disseminated TB. After doing a screen test with PPD or IGRA, anyone with a positive result typically gets a chest X-ray to look for signs of active TB disease. In patients with symptoms like fevers, night sweats, weight loss, and coughing up blood, or hemoptysis, it's important to collect samples from either the sputum or via bronchoalveolar lavage, which is where the bronchoscope is inserted through the mouth or nose into the lungs. Fluid is squirted, and then the fluid is collected. These samples can get sent to the lab for staining, culture, and PCR to look for evidence of Mycobacterium tuberculosis. Treatment of latent TB infection typically involves using a single drug for a prolonged period of time. The most common approach is isoniazid for 9 months. Treatment of active TB disease is typically done with different combinations of anti-TB antibiotics, like isoniazid, rifampin, ethambutol, and pyrazinamide. which results in patients being non-infectious to others usually within a few weeks. Until that point, though, patients can spread TB to others, and it's typically adults with reactivated TB that are the most infectious. As a result, patients are typically kept in negative pressure rooms, and visitors are asked to wear protective N95 masks that can't filter out oil aerosols, N for not resistant to oil, but can filter out at least 95% of other aerosols, in this case TB. Even after patients are no longer contagious, they're typically kept on multiple medications for many months to be sure the bacteria are destroyed, usually with direct observed therapy, or DOT, where somebody watches and confirms that you're taking the medication. Additionally, there's an enormous worry about new drug-resistant strains of TB that are causing infections in various parts of the world. You might hear of MDR-TB, or multi-drug-resistant TB, or even XDR-TB, which is extremely drug-resistant TB, which is incredibly hard to treat because they don't die in the presence of our usual antibiotics. The bottom line is to get an effective treatment. It's super important to make sure that the drugs being used will work against a specific strain of TB, that multiple medications are used together to prevent drug resistance from developing, and that medications are used for the entire course of therapy, so that all of the Mycobacterium tuberculosis is killed off. Recently, the US Food and Drug Administration has approved a breakthrough medication for XDR-TB, called pretomanid. According to recent studies, a combination of pretomanid, bedaquiline, and linezolid has been effective for almost 90% of XDR-TB cases. As an added bonus, this combination therapy can be taken orally, and is also very well tolerated compared with other XDR-TB drug regimens. Alright, as a quick recap, tuberculosis...
Alright, so, as stated in the video, so TB spread from person to person. Now, it is an airborne precaution. So when we were talking about the flu, I said that it was droplet and contact. So droplet, yes, you cough, you sneeze, the particles go into the air, but they don't circulate in the air for a long period of time, and they can't go far distances. They typically drop right to the surface areas on inanimate objects, like 3 to 6 feet. Tuberculosis is airborne. So the difference is, yeah, you are infected when a patient coughs and sneezes and they speak, but those particles can stay in the air for a very long portion of time. And that's why you need additional protection. A regular surgical mask is not going to do it. You're going to need an N95. If a patient is hospitalized, they are going to have to be put in a special room, and not all hospital rooms are specialized to be airborne precaution. And so we're going to talk about that because there's certain air filtration systems in certain rooms. And we'll get to that. So again, spread by airborne precautions when someone is sneezing, singing, talking, coughing, etc. And those airborne particles are evaporated into the air, and then somebody else breathes in that bacteria and can become infected. Now, the presentation of it, we classify it as primary, active, and latent. So primary tuberculosis is that the bacteria was inhaled and there's some sort of inflammatory response occurring in your body. Now, if your immune system is strong enough, the infection would not progress to a disease. But if it does, it can become active tuberculosis. So active tuberculosis could be from anywhere after 2 years of you being exposed. So it could become active, meaning that you can infect other people as well. And then there's reactivation tuberculosis, meaning that the disease occurs more than 2 years after the initial infection. So remember, active TB, you actively have it, you're having symptoms, and you can spread it to other people. Latent tuberculosis is you're infected, right? So if we did a tuberculin skin test, it would be positive, but that does not mean that you have the active disease right now. So you're asymptomatic. You cannot transmit the disease, so you're not infectious. But this can reactivate later in time and go back to active tuberculosis. And there are increased risk factors to that. If you become immunocompromised, if you have diabetes, right, because of that risk for infection that we talked about with diabetes, aging, pregnancy, stress, and any other chronic disorders because your body is in an immunosuppressant state. Remember, latent can progress to active tuberculosis, okay? Now, the signs and symptoms, they could take 2 to 3 weeks to develop after being infected, but they can also, right, in that case, develop within 2 years. So it's typically a gradual onset, and the initial symptom that we tend to see is a dry cough, but it'll eventually become productive. So that dry cough, it's irritating, it can become productive. Patients can complain of just lack of energy, feeling very tired, just overall discomfort. They also can have significant weight loss that is unintentional, and it's related to the anorexia piece of it, where they have a increased loss of appetite. They could develop a low-grade fever, so they have that mild fever that persists. And then you'll hear patients complain also that they're sweating a lot at nighttime. So that could be an indication too of tuberculosis. Late symptoms could be difficulty breathing and even hemoptysis, which is coughing up blood. Now, sometimes tuberculosis can present acutely and very suddenly, so it doesn't take a couple weeks to develop. And in that case, they could have a very high fever. They could have chills in result to that fever, so that feeling cold and shivering. They just generally feel like they have flu-like symptoms. They could complain of lower chest pain, have a productive cough. If you listen to their lungs, you could hear crackles over the tissue. And you see how a lot of these different things, you could be thinking, oh, well, that kind of sounds like the flu, right? So it does. And sometimes that's why a history and physical is not enough to diagnose individuals. That's why we need to go into diagnostic testing. And that's exactly what we'll do. So we'll get a tuberculin skin test, as you guys know it as a PPD. And essentially what we're doing is we're injecting a little bit of tuberculin into the dermal layer of the skin. So we're going in at about a 5 to 15 degree angle with the bevel up. So this is the bevel part and it's facing up. That's the angle. So you can push in and it will inject right into that dermal layer. And so what is needed to be done is we need to read it, and any nurse can read a PPD. So we inspect the site for induration, and the induration is just that palpable, raised, hardened, swollen area, and we measure it in millimeters. So you can see in this picture, right, this is the induration. Now in this picture, there's an induration, but there's surrounding redness. When you are measuring, you never measure the redness. You only measure the induration. So you're going from where it goes up to where it goes down on the other side. So just that raised bump is what we are measuring. Always in milliliters. Now the diagnostic, determining if it's positive or not, really depends on the patient and their risk factors. So make sure you know this, right? I could give a scenario and you would have to determine if they were positive or not based off of their PPD reading. And so, in this case, HIV positive, or if you're an organ transplant, the criteria is a lot smaller. So if you fit this criteria, then you're positive if you're a 5 or greater, all right? And then we go to 10 millimeters and who fits that criteria. And if you have no risk factors at all, then we give you 15 millimeters, all right? Now, why do healthcare workers have to do this twice? It's called a 2-step PPD. And the reason why is just because we come in contact with individuals, we're at a higher risk to develop it. So we're coming in contact with individuals that have tuberculosis. We're caring for these individuals. So we are at an increased risk to develop it. So that's why the criteria is more strict when it comes to tuberculin skin tests for healthcare providers. Additional diagnostics, and you can get this for the American Data Bank. You can get either a PPD 2-step or you can get this quantiferin gold blood test. So the quantiferin gold is basically just measuring your immune response to the tuberculin bacteria. And it's just seeing if your cells are responsive to the TB antigen. Now, the advantage of this type of test, it does give us rapid results, and it's more specific than a traditional tuberculin skin test, though it is very costly, so that is a disadvantage to it. Not all insurance companies will cover you to get this. In addition to that, in the video, it talked about the BCG vaccine, so that is recommended for individuals who are in high prevalent countries to get that vaccination to help prevent tuberculosis. So it's better diagnostic tool for those individuals who have received the BCG vaccine, because a false positive can result on a PPD versus the interferon gold. A chest X-ray can be helpful. It can show us signs of active tuberculosis, but it is not solely used to make a diagnostic on TB. But it is helpful to show us any lung abnormalities. The golden standard, why it's highlighted in yellow, is going to be the sputum samples. All right, so this will involve collecting 3 consecutive sputum samples in an 8 to 24 hour interval process, and it's typically very early in the morning, normally around the same time every day. Now, these sputum smears are stained and they're examined for acid-fast bacilli. And this type of bacteria is what causes tuberculosis. So if the smear comes back positive, it indicates that tuberculosis bacteria is present. But that's why we need this culture to confirm the diagnosis. Cultures can take some time to come back. It can take up to 6 weeks to actually confirm tuberculosis is growing because it grows slowly. Now, care-wise, talked about airborne precautions. So part of the airborne precautions is a specialized mask, as it's an N95 mask. It's designed to achieve a very, very close facial fit, and it is efficient in filtrating airborne particles. In addition to that, if a patient is hospitalized, they need to be put in a negative pressure room. And again, not all hospital rooms are negative pressure. So if I see a patient on our board to be admitted and I see tuberculosis, if we don't have a negative pressure room, they cannot come to our floor. So we would have to talk to bed management and get them sent to somewhere that did have an opening. Or if one of our rooms had a patient in there that didn't need a negative pressure, we could work by moving that patient and then getting the new tuberculin patient into that room once cleaned. All right, so a negative pressure room can just help prevent the spread of those airborne pathogens and contaminants from the TB patient to other areas. So those, again, with tuberculosis have to be immediately placed in this negative pressure room when they're admitted. Now, what is a negative pressure room? So because it's an airborne precaution, we need a specialized room that has special airflow and filtration and seals within it. So there's airflow management. There's about like 12 different air exchanges that are occurring per hour. And basically it's achieved by using an exhaust fan in combination with ways to replace the room air with like fresh air. In addition to that, they use special filtrations. So that's a filter that is basically recirculating the air to control the movement of those airborne contaminants. There has to be a proper seal for these air filtration systems to work. So that is why all windows, doors have to be closed, all right, for the system to fully work. And then obviously there should be an airborne sign before you enter the room. I stated the first day, make sure you're paying attention to those signs on the door. They're very important because it tells you how to protect yourself. And it also tells visitors how to protect themselves. This here is called a PAPR. You should be N95 fit test. Now, some of you have already been N95 fit tests. Those who have not, we are going to get you fit tested as well, because once you start rotations in the hospital, you should know what size N95 to wear, because it's a fit test that's done. So we spray something to ensure that you can't smell the particle that we sprayed, and that's how we know you have a full seal and it's the right fit. I have a coworker whose face she's just so tiny that none of the N95s fit her, and so she has to wear this hood, or PAPR as we call it. It almost looks like an astronaut suit, and it protects you the same way an N95 would. If a visitor comes, we try to limit them, but obviously they're welcome to come. They just have to understand the precautions and take the necessary steps. During COVID is an airborne isolation as well, but we didn't have the proper PPE to be giving out to the public. So visitors were restricted. We barely had enough to survive COVID as hospital staff. So visitors were restricted. But now that we have a better control of COVID and we have supplies again, visitors can come, but they have to see the nurse first so we can give them the proper PPE. Now, how do we treat this? Well, there's different drugs. All right, so different medication treatments, it depends on the phase of the tuberculosis. So in active tuberculosis, it's very intense the first 8 weeks to 3 months. Now, we know that these drugs can cause a lot of side effects. And so patient adherence is a huge issue. But if they're not taking the meds properly, resistance to tuberculosis can occur. And in that video, they were talking about that. So it's recommended that we do directly observed therapy or dot therapy. So this is typically done at a clinic where a nurse observes the patient actually take the meds. It can be expensive, but it is essential to prevent the spread of tuberculosis to the public. So what is the intensive phase treatment? Well, it's going to be 4 drugs, and I want you to remember it by RIPE. R for rifampin, I for isoniazid, P for pyrazimide, and E for ethambutol. The goal is basically to use all of these 4 drugs within the first 8 weeks to 3 months, and it basically reduces the bacterial load to prevent transmission from occurring. You need to understand these 4 different drugs, okay? So let's start with the R, rifampin. Rifampin blocks RNA synthesis, so it basically is stopping the tuberculin from growing. Now, all of these drugs, every single one of these drugs can cause non-viral hepatitis or liver toxicity. Because of that, okay, education needs to be done that they have to get labs drawn as often as the provider wants. We're checking their liver function test, all right? In addition to that, what else do you think you would tell the patient not to do, considering a major effect could be hepatitis or liver disease? Pause. No drinking alcohol. So they should not be drinking any alcohol. It will increase their risks for any of these. So I'm saying that now because every single one of these, I'm going to be repeating myself. So let me try to not do that. So side effect, liver toxicity. Rifampin can actually also cause red-orange discoloration of our urine, our sweat, our tears. That is a normal finding. So it's not, it's an education, so patients are aware of it. If they see their tears are orange, they could freak out like, oh my gosh, what is happening, right? So you need to provide that education, but that is normal, that body discoloration. Because it can affect our tears, we would actually tell patients if they wear contact lenses, they should not during this treatment and just to wear glasses. Then we go to isoniazid, and isoniazid does basically the same thing. It's killing the tuberculosis bacteria by inhibiting cell wall synthesis. Again, causes liver toxicity, but in addition to that, can actually cause peripheral neuropathy. Now, where did we hear this side effect before? Well, we talked about peripheral neuropathy where it affects the nerve endings in diabetics, right? So the same type of symptoms they could start to develop, numbness and tingling and like a burning sensation in their extremities. Now, what we could try to do to prevent this is actually recommend patients take vitamin B6 to prevent nerve damage from occurring. And then obviously liver toxicity, right? Then we have the pyrazimide, which is effective against dormant tuberculosis. So again, liver toxicity. But in addition to that, it can cause joint pain, nausea, and GI upset. The recommendation for this drug is to just drink lots of fluids to help with the joint pain. And then again, just looking out for signs of liver toxicity. Lastly is your E. This is your ethambutol. This is preventing tuberculosis from growing. Now, a major adverse effect, something we do not want, is optic neuritis. So this is visual changes that occur. So we recommend patients to get regular vision exams, as well as report any changes in their eyesight immediately. Another thing that can actually happen with the eyes is they can lose the loss of red versus green color discrimination. So they're mixing up red and green tones. Once we get out of the active phase, we can go into the continuation phase, which is about 8 weeks, and the patients will then drop down to two drugs, which is azonazide and rifampin. The goal is to eliminate any remaining bacteria and to help prevent relapse. So those are the phases. And then once you get to latent, they'll likely continue azonazide just to prevent the relapse from occurring and going into an active phase.
My name's Evan. I hope you enjoyed the video.